Welcome everybody. It is Friday, September 5th. I'm broadcasting here today from Boston, and we're here at the Curry Center at Northeastern University. Today we have an incredible presentation, something that we've had scheduled for quite a while, and we're just very grateful to Dr. Josh Brown from UPMC, who's the lead author on the Trauma Compendium, the NAEMSP position statement on pre-hospital blood products. And it turns out here I am today talking about whole blood. Whole blood is it's the topic of the day. It's going to be the topic of the next couple of years. And it's always great when the national organization puts out documents like these to guide us and to advise us and to make recommendations. And because what that does is it enables the folks who are battling and fighting the fight in their own jurisdictions to say, look at what's coming from the National Association. So if you're not familiar with NAEMSP, it's a national EMS, National Association of EMS Physicians and Paramedics, so that P is both physicians and paramedics. If you're not a member, you need to join. This year's conference is in January in Tampa, Florida, and we'd love to see everybody there. So without any further ado, Dr. Brown, thank you so much for joining us. If you want to make further introductions, thank you for joining us, and take it away, my friend.
All right. Well, pleased to be here. I appreciate, I think, making my second appearance with you and the previous one was to talk about pre-hospital transfusion as well. And I'll just say, I may be a bit of an anomaly since I'm a trauma surgeon and not necessarily an EMS physician or medic, but I spent the first 10 years of my career as a medic up in Buffalo, New York. And so my lab really focuses exclusively on pre-hospital trauma care. And know a few of the folks, and I'm a member of NAEMSP, and so they asked us to put together this position statement as part of their trauma compendium, which I think is a overall great series. So if you haven't seen it, check it out for sure. So nothing to disclose, and we did this of our own free will with no payment to do what we did here. So I do want to acknowledge, this really was a team effort. These are the co-authors on the position statement, and these folks volunteered their time to review over a couple thousand abstracts to really distill down the evidence around pre-hospital transfusion and try to answer some of the questions that we came up with. And really also shout out to Chris Martingale and John Ling, who were at NAEMSP, who's really coordinated this effort and kept us on task and making sure that we were meeting the deadlines and that we were doing this in a robust way that met the standards for the organization. So, what I'm going to talk about is really kind of a systematic review and some guidelines, but, and that could be pretty dry. So I'm going to start with a case to try to make this a little more interesting. And this is a 26-year-old male who's an unrestrained driver in a motor vehicle collision who had gotten out of the car, and then bystanders said there was maybe some seizure activity, lost consciousness. When we got to him, he was talking, he had a patent airway. You can see, bilateral breath sounds, sats were fine, but you can see his first blood pressure is 57/42, heart rate of 168, and his pre-hospital lactate that we measured was almost 18, right? Abdominal pain, rigid abdomen on exam. So why do I bring this case? Because this is the picture I took from the helicopter as he landed. So as a trauma surgeon, I still go out with our air medical crew, and try to provide some pre-hospital care and stick to my roots, right? And this is the blood that we started in the back of the ambulance for this gentleman before we moved him to the aircraft. Right. So they had gotten an IO. We put in some IVs, got 2 units of blood en route to the trauma center, right? Even before hitting the deck. Remained hypotensive, tachycardic in our trauma bay, positive fast. My partner gave him 2 units of whole blood while we packaged him up, activated our massive transfusion protocol, got a gram of TXA, and went to the OR. And from the time that we hit the helipad to the time that they made first incision was 21 minutes. Right. And so, I bring this case because this is a bleeding patient if we've ever seen one. And we know that hemorrhage is really the leading cause of preventable death in trauma patients in both the civilian and the military setting. Patients who might have survived but died is because they bled to death, and that we could have potentially prevented that. All right. And because of this, on the trauma center side, we've really, over the last decade or so, stood up this idea of damage control resuscitation as an approach to these bleeding patients. And there's really four main pillars, and permissive hypotension until we get surgical control, right? We don't want to pop the clot and push their blood pressure up to a normal range to just increase the blood that they lose. Minimizing crystalloids, right? We've discovered that crystalloid really is poison to these trauma patients. And time again, it revs up your immune system, it increases acidosis, and as one of my co-authors on the paper likes to say, salt water is for pasta, not for trauma patients. Right. Early hemorrhage control, getting them into the operating room. I told you my partner had this patient in the operating room, making a decision within 21 minutes, no time to mess around when this patient's bleeding to death. And then, of course, one-to-one resuscitation, and really more recently, whole blood that accomplishes that. And so these are the pillars. And we've been pushing this out into the field, right? And even going back to the 90s with the Bickle paper looking at permissive hypotension in the field for penetrating torso trauma. We've documented even, within minutes of giving someone crystalloid, you now have an aberrant coagulation system. They're not making clot. They're acidotic, and that pre-hospital crystalloid, can be detrimental. Right. Tourniquet. When I was a medic, we didn't even carry one. We were told you might as well cut their extremity off if you put this on. But we now know, right, that these are life-saving, and that is the standard of care now. Right. But now we need to push the fourth pillar out into the field. And we really have started to see that happening with blood products and whole blood taking hold. Right. And for a long time, access to blood products in the field has been a way of largely critical care transport and air medical services, and there's a lot of logistics that go into this. The picture on the left is one of our stations at Stat Medevac. All of our bases have been certified as satellite blood banks in Pennsylvania to manage this, right? But we know that this is now being pushed out into our ground EMS agencies, and access is expanding from Florida to Pittsburgh, right? And across the nation, we're seeing blood in the field, regardless of the type of agency and capabilities. And that's because a lot of this has come way of advocacy from groups like NAEMSP, getting protocols and scope of practice change so that we can offer this life-saving treatment in the field. And so as this access to this treatment has expanded, even in Pennsylvania, for a long time, again, we were able to get blood in the field on our air medical services. But just in 2024, we changed the protocols, and now all medics are able to give blood as part of a Pennsylvania protocol. So again, this is expanding the scope of practice and access to this. So in that landscape, we wanted to review the literature on pre-hospital transfusion and trauma patients and try to systematically develop some recommendations. Again, as they say, if you've seen one EMS system, you've seen one EMS system. And so a lot of people are in different phases in dealing with this. And so, at the national level, NAEMSP wanted to provide some recommendations around this. So really our first task was to figure out and narrow down the questions that we wanted to ask. So we ultimately came up with 3 PICO questions that we thought were important. And for those that may not be familiar, PICO stands for Patients, Interventions, Control, and Outcome. And so really a way for these systematic reviews to narrow down and focus in on a very specific question and look at the literature to try to answer that. So our first question really was looking at trauma patients and hemorrhagic shock. does giving them blood products compared to crystalloid improve survival, reduce the need for subsequent transfusion, or improve physiologic measures on arrival to the trauma center. Second one was to then look at whole blood, as this is really taken off and expanding in the pre-hospital compared to other blood product components to see if it impacts those outcomes. And then lastly, we wanted to look at an EMS agency level who have blood product transfusion programs. What are some of the best practices around the program and managing, blood supply, storage, and the logistical approaches to how to run one of these programs, and try to provide some, practical advice or help to these agencies that might be thinking about starting one, or how we can do this better. So we did perform a structured literature review looking at PubMed and Ovid databases from January of 2000 to February of 2023. And we really wanted to look at patient level data, so we got rid of case reports and non-human studies. And we did a structured evidence evaluation where we looked and pulled out all of the details of each study that we found in relation to each of the PICO questions, and also aggregated the results to report those. And we developed systematic recommendations for the first two PICO questions, meaning, we looked at the evidence, and based on the evidence that guided our recommendations, because, those questions were pretty focused of yes or no, that, is there evidence supporting that there's benefit for those interventions. We developed consensus recommendations for PICO 3, really around best practices and what we thought could be helpful from a programmatic standpoint. But that question's a little bit more nebulous and less hard evidence to say this particular recommendation has multiple papers behind it. We wanted to develop a resource document that includes all of the studies and the information relevant to each PICO. And so that, for those folks who want to, really review this literature and see what the evidence base is, or, needs that evidence to take to, leadership and say, here's what the evidence says. That was a resource for people. And then, our final recommendations were reviewed and approved by the NAEMSP Standards and Clinical Practice Committee. So this is what we came up with, just over 2,400 studies that we screened those abstracts, and got rid of most of them, and got down to 136 papers that we got the full text for to read the full study. Out of there, 68 of those didn't have outcome data relevant to what we were looking for, and 3 we couldn't get an English translation. But in the end, we ended up with 66 studies in the review. 32 applied to that first PICO question around blood versus crystalloids, 6 that applied to the whole blood question, and then 37 that applied in some way to sort of our programmatic question. And so, you can see obviously, in that total is greater than 66, and some of those studies, applied to more than one question. Right. In the paper, and I encourage you folks to read that, we go through each of our recommendations and kind of provide the rationale citing that literature, but I'll, give you guys the bluff or the bottom line up front of the recommendations. And so for PICO 1, we recommended the use of blood components over crystalloids for first-line treatment of patients with traumatic life-threatening bleeding, really based on, the weight of evidence supporting a likely benefit, absence of a harm signal and adverse events in these patients. And also that we know crystalloid can cause harm. In PICO 2, we recommended the use of low titer group O whole blood as the first choice for blood products for these patients. Based on largely similar outcomes with other component therapy, but also the logistical benefits, right, of whole blood versus carrying packed cells and plasma and potentially platelets. And then in terms of programmatic outcomes, we recommended using a combination or some composite of pre-hospital transfusion indications, really focus on physiologic abnormalities and injury patterns in patients with obvious significant potential for blood loss. We also recommended use of active monitoring for transfusion complications or adverse events. Almost never have seen these, but it's important to monitor as this type of treatment and program spreads across the U.S. Right. We also recommended developing a mechanism, right, to you recycle the unused blood products nearing their expiration to a high use facility to minimize wastage. And that's really important that we're good stewards of this resource, as well as engaging in a comprehensive and longitudinal collaboration between the EMS agencies, trauma centers, and blood suppliers, right? This really needs to be a team sport to make this sustainable and make sure that we're doing this the right way. The other thing that we thought was really important was thinking about some implementation considerations, right? And we recognize there are significant clinical, logistical, regulatory, and financial burdens of pre-hospital transfusion programs. Many programs are either, you taking the costs on themselves because we believe that this is improving the outcomes for our patients. Many are working through various, government or local grants to run these programs. And we recognize that not every agency is going to be able to, be able to have a transfusion program, and so thinking through those implications is important. It's also important to think who's going to carry the blood, how much blood you have. Is every transport ambulance going to have it? We just went through a GIS study with the City of Pittsburgh EMS. We're going to put them on our rescue trucks, right, that are dispatched as medical backup to most major traumas. All right, and that's going to be different for every agency, whether supervisors carry them and how you'll store them as well, right? And I think there's room for improvement and dispatch criteria and transfusion indications, and that's a very active area of investigation. Right. Supply sourcing and cold chain maintenance challenges are real. And this is really where having an ally in your blood supplier and transfusion medicine program helps. And, we looked at programs like Brothers in Arms or Heroes in Arms down in Southern Texas, where they maintain a core group of folks who donate, and that blood is specifically designated to become whole blood for their pre-hospital transfusion program. Right. And the recycling arrangements for sustainability, again, that's going to vary widely, is really a very unique local phenomenon, but setting those up and making sure that that is a smooth process to minimize wastage. Right. Reimbursement. And I think this is something really where advocacy is going to become important so that agencies who are providing this really critical intervention can be appropriately reimbursed. And so there's a number of efforts sort of at the national and local levels around how we can change things so that we can get reimbursed again, so that some of these agencies who might otherwise have to take on the costs themselves and may not be able to do that might have access for that. And also thinking about health equity and community engagement, right? We have, in an area, a large Jehovah's Witness population, so engaging them, about this, and it's something that we really, spent a lot of time doing in some of our trials, to make sure that the community is engaged, and those that might not want those treatments, appropriately informed and can have their input valued as well. So there's certainly limitations to what we did, right? The evidence base for this is largely retrospective and observational. There were 4 trials that really were randomized trials around blood products and 2 prospective cohorts. So the bulk of the evidence supporting this is observational, although I think we don't always need a randomized trial to say that a treatment is effective or not. And I think that what we saw was that the bulk of the evidence supports this. Right. And the literature is rapidly evolving. The day we finish our literature search, we're already out of date. And, since 2023, there's been many more, really good and interesting papers on this topic. From a methodologic standpoint, given our personnel and financial limitations, each of the authors, did single screening and full text review with me doing about a 10% sample double review just to make sure that we were capturing everything. And the last thing is we didn't do a formal or standardized grading of the evidence or risk of bias. So this wasn't a grade review, and so we couldn't speak to a standardized assessment of the strength of each of the papers included. So you're returning to that case, this patient ended up having an avulsion injury to the liver, and we ended up vascularly isolating the liver and getting a left liver resection and leaving him open. So what that means is he basically tore his liver off the IVC, and so we had to clamp above and below the liver on the IVC as well as the the porta and the portal vein to stop the blood flow so we could see enough to do our resection and repair that. You can see you got quite a bit of product in the OR, and ended up losing part of his liver. Left him open for a few days. He also had dislocation of the right hip, acetabular fracture that got fixed by ortho. He developed renal failure, went on dialysis, pneumonia, bile leak, DVT, but was discharged 40 days later to SNF and was back at work in 5 months, right? And I would submit you to the group that I don't think he makes it to our trauma center if he didn't get blood in the field and sort of the massive transfusion and all the things that we've developed around damage control resuscitation and push that out into the field. So, really the conclusions, we think the weight of the evidence supports pre-hospital blood transfusion for trauma. We saw an early mortality benefit and really a reduction in the total transfusion requirements for these patients once they got to the trauma center. No increase in the risk of adverse events in any of the studies, including all 4 of the trials. Right. And I think the whole blood is really going to be the preferred option, not only for the benefits, but as well as the logistical, advantages over some of the other blood products. But again, this really needs to be a team sport with a lot of players and stakeholders at the table to make this work, and ongoing advocacy for the reimbursement, again, continuing scope of practice, access, expansion. Not all of those states on that map I showed you allow pre-hospital transfusion, or some are limited to pilot programs, as well as advocacy to the public around the life-saving benefits of this so that we can support sustainability and donation efforts for these types of programs. I'll put a plug in for the Pre-Hospital Blood Transfusion Coalition. I think they put together some good resources around developing these programs, cataloging who's doing this, and really trying to push forward on the advocacy front around access, increasing scope of practice in areas where that's limited still, and really have tried to take on the issue of reimbursement to make this a sustainable prospect for most programs. So that's what I have for folks. Again, I really appreciate Peter you inviting me, and certainly happy to take any questions or and entertain discussion.
Yes, and I hope that we do have an active discussion. That was an amazing presentation. You really, at least for me, Josh, I would say that this signals to me a major change. Like we've gotten over a big hurdle now that you and all your colleagues and the NAEMSP has put out this publication. And the reason I say that is, many people have been trying to get blood on board for many years. Obviously, it started in the state of Texas and San Antonio. And then what we've noticed is that as it started to get out from San Antonio into places like, Florida and DC and New Orleans, et cetera, that there was a massive amount of resistance from, you name it, trauma surgeons, other EMS folks, et cetera. And everybody's waiting for that RCT. Unfortunately, the randomized controlled trials, and I'll use refill as I'll kind of pick on refill trial, which didn't really demonstrate a benefit because the patient was getting the blood at 55 minutes. So finally here, you guys were able to kind of peel away and try to get to really the source of truth. And I wonder if you could really just describe what are some of the barriers that you're seeing? Because there are entire states who are not yet for whole blood in the pre-hospital setting. What are some of the barriers that you've seen? And then do you think that this position statement will finally be the turning point where an agency in Iowa, Idaho, Massachusetts can come and say, here's a document, and we don't need to wait for the second and third and fourth RCT to show that the hemorrhaging patient, like the one you had in your helicopter, needs blood. I wonder what your thoughts are on that.
Yeah. Yeah, I mean, I think, and I think we could probably do a whole, a whole edition on, some of the issues with refill and some of the other trials. And, what we found, especially as you come into the whole blood era, is that, it's really become standard care. And so the ability to do trials going forward, that randomized trial compared to a placebo or, is really going to go away. And we found that, and we're finishing up, our Tower whole blood trial pre-hospital. But, a big limitation is really is going to be compared to plasma or packed cells, because of, of Pamper and some of the other trials that did show benefits. It's really, the cat's out of the bag. And so that's why I think, it's unreasonable to wait and say we got to keep doing these trials, and start to turn our attention to how do you build a sustainable program, and how do you identify the patient who's most going to benefit from transfusion. And I think that's really where the investigation needs to go. In terms of the barriers we're seeing, I think one of the things we've been very fortunate in in Western Pennsylvania is that we have in Mark Yeaser, a sort of tireless defender and advocate for whole blood, both for, in hospital and pre-hospital transfusion. That's, not the case everywhere. And as we've, talked to other centers and other EMS systems, moving across the state, they've seen a lot of barriers from their transfusion medicine folks and say, we're not doing this in the hospitals. Why would we give you whole blood? And so, trying to break down those barriers and show them, this evidence that this is really becoming standard of care, and that finding unique ways to make sure that the units get recycled appropriately, especially in some of our rural partners where, they may not have the big trauma center. They can drop the blood off, and we know that's being used, within a couple of hours in our OR or something like that. And so, we've been trying to, find creative solutions, and really pushing the advocacy piece that, if anyone on here, Mark is always willing to kind of go talk to the transfusion medicine folks. And so, I'm always happy to farm him out to folks who are meeting resistance from their transfusion medicine people, because he, has been doing this for a long time, and has been able to help, soften some of that resistance.
Excellent. I want to go to Dr. Pepe, then Dr. Shepke, then I want to go to Tanner. But Paul, you've been on the front lines. Are you able to talk, Paul? I wanted to get your comments here.
Yeah. Can you hear me okay? Can you hear me
we
okay?
can. Yes.
I'm in a noisy spot here. So I want to apologize to everybody. First of all, are you then recommending that we should be holding these life-saving crystalloid fluids from people? That's really concerning to me. I think it's not right. So, just kidding. I'm being sarcastic, because we were talking about doing this, whatever, 40 years ago.
Yeah.
But I mean, it's great. What we were saying is just having Peter was saying, having that, and what you were saying, having this kind of, backing and thoughtful process. And I think you're right. The randomized controlled trials are just going to is that I've become very skeptical now, both in cardiac arrest and trauma. Even though I was the person to first do these things for us in EMS, I was got really skeptical because of all the confounding factors. But the way you articulated just now, especially with Hamper, especially with all the other strong data, I think we're seeing a tremendous difference. So thanks for doing this and all the work that you put into it. Sounds like you're very thoughtful and you're very conscientious, covering a lot of different studies that give you sort of partial information, but sounds great. I don't know what else to say except to pass it on to Ken Shepke and talk about what we're going to be doing next, hopefully in Florida.
Yeah, so I want to set Ken up here because what Josh spoke about, and one of the beauties of this talk just now, that it wasn't just that the clinical here blood works, but there's so many things that go around with actually getting a blood program set up, and you really do need some support. And I think that support is a statewide support. And when you have someone like Ken Shepke as the Deputy Secretary of Health for the state of Florida, who's a mover and a shaker, and he actually understands what's done in the field, we could actually get things done. So Ken, I'm going to pass it over to you. And if you could talk about, Dr. Brown's talk and just any comments you have moving forward in the state.
Yeah, first, thanks so much for the talk. Fantastic talk. And I think it kind of shows what we're all expecting. And Peter pointed out I don't understand the mentality in medicine that we need a double-blind, placebo-controlled, randomized control study for something that's painfully obvious. I mean, where's a randomized double-blind control study that we should continue what we're doing with the life-threatening crystalloids? So, I'm just on the opposite side of that coin. When it's obvious, we really need to move towards it. If you're leaking out red stuff, replace it with red stuff. Of course, it's going to work. So as far as the state program, we are envisioning a statewide program. I put in a budget issue proposal this year for our legislature. So if we get the funding, we are envisioning a statewide blood program that handles the logistics, handles the evergreen supply issue. You won't need to contract with your individual local hospital. We'll handle that through this statewide logistics center. We'll make sure they use the proper packages to extend the shelf life of the blood products to as long as possible, because for those that don't know, there are different containers, and some of those containers shorten the shelf life. And we'll work on increasing the donation supply as well. And of course, we'll be working on the data that Dr. Brown was talking about as well. We'll partner with a number of hospital liaisons whose jobs will solely be to give us the hospital outcome data. So we'll be able to do a number of logistical and quality studies. And that I think could solve the problem. But we are in a Doge sort of environment with all the governments. And I'm asking for $15 million. And you guys who've been on the call before heard me say that. That's what I'm looking for. So hopefully we can get this, because this is a tremendously life-threatening program. We've already seen this in Palm Beach County. We've seen miraculous outcomes. And we already know the National Highway Traffic Safety Association data shows that the folks like us in Palm Beach County that have this, we are so much better than the state average for survival for car crashes. And that's just one example. Obviously, you use this for GI bleeds, for OB bleeds, for like Izzy in our county. If you saw the news report on Izzy, who had a post-tonsillectomy bleed, it saved her life as well. So I think it's really, really important that we all rally around this. We know it's the right thing to do, and but we are going to need the support, because we're in sort of a frugal kind of area from the government standpoint. Everybody's belt tightening, and I'm asking for more money is going to be an uphill battle. But we have the framework for how we can design this and be a best practice for the nation. So let's hope we can get it through.
Hey, Dr. Shepke, you're not going to give it to kids, though. You're not going to give blood to children, are you?
Well, you shouldn't treat kids like little adults, because kids don't grow up to be adults. So you have to treat them completely differently. They grow up to be a horse or something else, apparently, which, as Dr. Antebi keeps pointing out to us. So obviously, kids have to be part of this as well.
Yeah.
The reason, and the reason why I'm bringing that up, Peter, you could tell that, right?
Yeah. And Don Jenkins, Dr. Jenkins, was so grateful to send me the abstract that he just submitted to the Western Trauma Conference that he hasn't presented yet, which showed that the number needed to treat to save a pediatric life is 6. It's insanity, right? The number needed to treat for epinephrine for survival is 112, right? So an NNT of 6 is unheard of, and it's pediatric patients. So Ken, thank you so much for the commentary and for your leadership. I want to move to our resident research guru, even though he's not a Florida resident, we're trying to make him move to Florida. But Tanner, you've heard Dr. Brown. I know that you've heard him here before in the webinar, and you're hearing all this randomized controlled trials, the excluded case reports, et cetera. What are your thoughts here about the future or the current status of the data, and then where this takes us into the future?
Yeah, so before we had Pamper, right, which established that adding plasma to standard care seems to improve outcomes from trauma. And then I knew that we had the Tower trial coming up. So before this presentation, I went and I looked on the clinicaltrials.gov registration, and I saw that it looks like follow-up for the primary outcome concluded mid-August, according to the website. So and that compares, as you said before, whole blood versus standard care. And so I guess I'll ask you, Dr. Brown, when can we expect to see the results of this study? If you have any inside information on that. I know you probably can't share any results with us, but
yeah, no, they just locked that data set and the analysis is going on. So I suspect sort of within the next 6 months we're going to be looking to submit that, present that somewhere, and get that published. So I think we're excited about that trial coming out.
Can I interject real quick? You had mentioned it earlier, Josh, which is that you're comparing in Tower whole blood versus component. So you're not really looking at, like, when you say standard of care, it's not that you're going to be comparing it to crystalloid, right?
Right. And we have, some of it set up a little bit, and for those that might have done some deep dives into Pamper, and one of the other papers we wrote out of that was, because it's multi-site, and Pamper, some, like us, we were already giving packed cells. There were patients who gave plasma and packed cells, and incidentally, those patients did the best, even though they were severely injured, right? And then there were some that still were just had crystalline. We're not carrying packed cells, so we do have some inter comparisons, but by and large, it's really whole blood versus components. And for us, I think even when we started this, we think that it is a win if there's no difference, right? That if whole blood is good, then you're getting the benefits, and now you're not necessarily carrying packed cells and plasma, the logistic benefits. And I think, that echoes, some of the comments earlier, that it's not that, this paper, and we set out not really just like, give blood, but there's so many logistics to go into it. And, I think that's something that I, as an investigator, always tried to hold on to around pre-hospital care, is that, this has to work in the field, and you have to understand, the environment and the limitations. And, I could put in a machine learning model that says, give, this patient 113 cc's of blood, and any paramedic, on here is going to laugh in my face, right? Because that's just not, how it works in the field. And so really keeping, an eye on how we can translate this stuff into the environment it's going to be used in, and be realistic, I think is really important part of this.
Well, it's always nice when the trauma surgeon was a former paramedic. That's the benefit to you being in this seat, Josh. So let me bring it to my Associate Medical Director, Dr. Charlie Ingram. Charlie, take it away.
Yeah, so pleasure to meet you, Josh. I think something that we're missing a little bit is the logistics, right? Like these logistic pieces, and I'm glad that it's somewhat and like looked at in the position statement, because it's so important, right? Like we run a system in Davie down here where like we have 2 blood units from Broward County that flank Davie. Like, do we need blood there in our organization? Like, I don't know if we do, right? Like, I can't think of any patients that I wanted a blood unit and we didn't get one, right? And so I think that like we probably have an opportunity in the research realm, similar to what you're doing with the like GIS data, and look at our trauma data sets and look at our like zip code data to be like, where do we need these units? Because like Ken is saying, like we are begging for $15 million and we hope to get it, but when we don't use it to the best, like super efficiently, we will run out of resource again, right? And so I'm hoping that we can kind of combine efforts somewhere across the country to say like, okay, we know that we need fire departments that are X like distance to the structure fires. Like how far do we need blood units from high trauma volumes from medium trauma volume places to say like we're still seeing a benefit and we're not wasting resources, right? I don't know. I think that that's kind of the next piece that I really want to investigate on our end for sure.
Yeah, I think one thing that's really that's come out of GIs too is in Pennsylvania everything's little townships, right? And I mean some of them are barely keeping the lights on, and so it's unreasonable. But looking at a system level and from a state level, how do we still get blood to those communities if they need it? And what's the radius? And if this agency or like UPMC, you've got a number of advanced critical care paramedic fly cars that support, right? When you're in a rural area and the plumber's driving the ambulance, we can rendezvous with them. We're carrying blood on those. So how, from a system level, we can support these areas where it may not make sense to have, a continuous supply, but still, take care of those communities at the highest level.
Yep. Yeah, absolutely. And it takes a village, right? Like it takes a real logistic system. And I think that's a big thing, like for these state funded pieces that we're hoping to get down here, like they should be regional assets, right? Like it should be part of that, I think, too. So yeah.
Agreed. Great comment, Charlie. And I want to bring it now to one of my mentors who brought me into EMS, Dr. Wayne Lee. Wayne, take it away.
Gosh, Peter, I always appreciate you saying that. Keep sending the checks, please. I ramble on about this, and I'm probably going to ramble, but I think there's a question in here somewhere. And first of all, I really appreciate the presentation. And we've been following this for a long time. I work for the Seminole tribe, and we have 4 reservations. They're spread out. Many times they're geographically undesirable in terms of transport times, etc. We are a low volume system, essentially. Most of them come out of our casinos. And but at the same time, we have industrial accidents and so on and so forth. So I'm really happy to hear what Ken had to say, and I assume that he's talking about $15 million per system, right? We took a shot a year ago or 2 years ago, and we were trying to justify an investment of about $200,000 a year for 1 case a year. And so one thing and I'm sort of critical of these presentations in a couple of ways. One is that I did a lot of defense work, so I always get a little bit uncomfortable when we start talking about standard of care. And so what I heard on this was standard of care is whole blood. And that puts a lot of pressure on me and a lot of other systems that probably have less volume than I do. And we look at other places, New Orleans, which I don't think they're using whole blood, and yet they have a lot of volume and a lot of application. So I think we need to talk a little bit more, and I'd be interested in what science there is out there, or who has looked at. We do that, and again, I'm rambling here. We do that national map, and we color the states that are actually using whole blood, and almost everyone except my home state, Arkansas, is using whole blood, which I'm not sure what that means exactly, but at any rate, but what it doesn't show is how many of those systems in those states are high-grade, high-volume systems, that have the access to blood or maybe the financial ability to purchase blood, if you will, to get blood, et cetera, et cetera. So nobody looks at how many systems do we have that are low-volume systems in remote places that have the 1 or 2 or 3 cases a year, maybe, that need blood. And shouldn't there be a lot more discussion about alternative methods? Rather than simply whole blood? And shouldn't we be looking at and maybe having presentations from low volume systems that have been successful in obtaining blood and or an alternative product, to deal with that? So I think that's my comment. I guess there's a question. I'm interested in any feedback on that.
Yeah. Yeah, because you mentioned Ken's name, I'll go to him first, and I'll go to Paul, and then I have some comments on that too. Go ahead, Ken.
Well, first, Dr. Lee always has, some wise comments. So he just needs to run for the legislature so he can up my budget proposal. So it is 15 million each. So I was trying to be realistic. But a couple of things for a system like his that has low volume, it might be more logistically realistic to use plasma as opposed to whole blood. Now, the system that I'm envisioning is actually an evergreen system. So your agency would buy the unit and it would stay good until you end up using it, because you would just take your old one, send it back to the logistics center. The logistics center will send you a new one until you finally use it. Obviously, there's an EMS reimbursement piece. I haven't talked much about that, but I'm pushing for an EMS reimbursement piece as well. That's a separate thing. That's a whole other talk, so I won't take too much into it. But I'm trying to solve that issue as well, that you can actually get that piece reimbursed. But I would say that the smaller lift with not quite as good benefit, but still excellent benefit, would be the plasma. And if we ever get that European freeze-dried plasma here in the United States, that's really going to solve some problems. The system I'm talking about, Wayne, just and for everybody else, we're looking on average to put maybe it's going to be regionalized. Without getting too much detail, it's not going to be every truck. We're looking to have like a regionalized system where you've got one unit that carries this, that serves an area, so that it's actually becomes somewhat affordable and we don't waste resources.
Yeah, I would double down before I go to Paul. I would double down on the fact that plasma is the way to go. $60 per unit. When the spray dried stuff comes out, supposedly 2026, it's 2-year shelf life. You add 200 cc to sterile water, you shake it up, and you're on your way. So that's probably more realistic, Wayne. And I think that Pamper has shown that, and I think plasma, like we started using it for TBI, we started using it for burns. We're now adding it on for sepsis. I just got the green light for that. So I think plasma is more of the Swiss Army knife, and then obviously reserving whole blood. But we have many patients. We had a patient actually last night, 11-year-old female, ejected 30 feet on the highway, and she got plasma and she got TXA, and now she's let's see how she does. But on Monday, just one county north of us, and this kind of goes to Josh's story. One county north of us, there was an accident where 2 people were killed, or they died on scene, I should say. And then other 4 people are severely injured, no plasma, no blood. They just needed diesel fuel. And so there's a big disparity, and that shouldn't be the case. And I think that's where Wayne was going. But Paul, let me go to you with your comment.
Yeah, my window's closing here pretty quickly. Yeah, I think they're calling. But anyways, 2 things. One, I was going to say what Ken said. We could probably put, and what you said, plasma and TXA on every ambulance, and that will get us to start and even buy us time for blood. May even obviate, and it'll give us a larger number of patients. We're not giving the blood products to enough patients right now. There are many people who could use it, and we've restricted it because it's a precious resource. So that's the other thing I wanted to say was, one, as we go forward, let's research this so we could see if there are people we could exclude, such as the people that we confirm have not a non-beating heart and they've been down for a while. One thing I also have been doing lately, what we did down in Broward Sheriff's Office, is that we've seen that this is applicable even in blunt trauma cases. It's been very helpful because most of the data have come out of systems with penetrating injuries. And so that's been an exciting news. But I'm saying it's time for us to start breaking it down. The most important thing, though, I wanted to say was that what we've done in Texas, particularly in Bexar County, which is where San Antonio is to create a regional resource so that places that are smaller towns can have the blood brought to them, or be part of a regional alliance, so that you don't have to stock the blood in individual places or at Seminole or wherever it may be. We just have mutual aid, and that could be a thing that regulatory wise could be overseen by the states. And that's why we have these great advantages with people like Ken.
Yeah, or even drone. The Villages apparently is starting a blood drone
I'm
program.
sorry, say that again. I
was saying even drones. We had looked at drones,
Yeah.
but there's some issues with line of sight and the FAA. But apparently those restrictions are being released slightly. So let me go to our good friend David Long from the Tidewater EMS region. He was a single factor behind a very widespread blood program in Virginia. He's ex-military. He's really good at what he does. But David, you have a question about hospitals and what's going on. And can you unmute your microphone and make the comment? And I'd love to hear Dr. Brown's response.
Yeah, so we just recently established regional trauma advisory committee, and as we started talking through the use of whole blood in our region, with all of the regional trauma centers, participating now in the conversation, we learned that our level 1 trauma center only carries a total of two units of low titer, whole blood in the hospital at any given time, so that the majority of their, blood products are component therapy. So when we look at this, kind of dichotomy of we're carrying low titer O positive whole blood, in the pre-hospital space, they're using component therapy in the hospital. And does this dichotomy, contribute to this difficulty in closing some of these gaps, or how does that potentially impact conversations moving forward and establishing new programs?
Yeah, I think that's interesting. Because I think part of it definitely has to be the buy-in from the trauma centers, and admittedly, even among my colleagues in trauma surgery, not everyone is convinced, and is doing this. And I think that there is some data out there suggesting that the proportion or dose of whole blood that you get as your total resuscitation matters, as well as again, if you are looking at a component resuscitation, if you're falling below 1 to 1 to 1, you start to see the outcomes drop off very quickly. If you can actually maintain it, some of the data suggests that it can be equivalent to outcomes from a mostly whole blood resuscitation. But you were looking at only a third of level 1 high functioning trauma centers in TQIP that have been able to maintain those ratios. Things get in the way, and so that's why we have 6 to 8 units of whole blood in our trauma bay cooler, because you really start to get sidetracked, and the whole blood's the automatic 1 to 1. And so we've done that because we know if you start to fall behind, your outcomes start to drop off. And so that, I think that raises an interesting question, is maybe, when we start to look at some of the longer term outcomes, we know, right, what happens at the trauma center is going to impact that. And so if you guys are in whole blood and they're doing component and not keeping up, that can impact, sort of from a research standpoint, whether or not we're seeing the outcomes, the potential outcomes that those patients could have.
Right.
I did want to to Dr. Lee's point. I think you're right about the semantics and this idea of standard care, and we were very careful in the position statement not to make that claim, because we, again, knowing the logistics and the challenges, not every system is going to be able to do this, and you can't, that's not the position we want to put other systems in. And I'm definitely, I think the freeze dried is going to be the game changer that really opens up the access to every trauma. I mean, once that comes out, it's going to be in my kit in the back of my car.
Yeah, 100%. Yeah, we can't wait. And Tanner, I see your hand up. Go ahead, my friend.
Yeah, so I had 2 questions. So the first is related to the lyophilized plasma. I know at the University of Pittsburgh, there's a lot of work going on looking at some of the molecular mechanisms that underpin the relationship between blood products and outcomes. And so I was just wondering if you had any thoughts on the difference between the molecular effects of freeze-dried plasma on the immune system and the glycocalyx, et cetera, versus FFP or thawed plasma. So that'd be my first question. And then second of all, we talk about, systems are kind of generally moving toward whole blood anyway, and the need for future randomized controlled trials in that space and the feasibility of them. So I want to ask you, as someone who has been at the forefront of transfusion science for a while and has been kind of behind closed doors, part of a lot of the conversations about the future of the field, if you had an unlimited budget and a research team, what do you think the next big trial is, or the next thing that we need to investigate as a community of people who are interested in pre-hospital trauma resuscitation?
Yeah, so I think, for your first question, I mean, that's on the docket, and as part of the Lights Network, as soon as that becomes FDA approved and available, is going to be part of that trial that we run through the Lights Network, and looking at, the animal data would suggest that there's similar benefits, but there are some differences, and so we do want to look at that because I think what we found with some of the molecular mechanisms and the endothelial stuff, it probably drove a lot of the benefit in blood polytrauma patients who have TBI. And I think that is probably, a frontier where I think we need to go next, is really, starting to, break down who are the patients and the populations that benefit from these various products, whether it's plasma, on its own. Because I think, Lights is starting the burn trial for plasma. And so Peter, you're ahead of the curve on that. And I know, some of the folks here were talking about a sepsis trial as well. And then certainly, sort of my interest is how do we identify those folks in the field, and what technologies can we bring to bear to do that in a more accurate way than the National Field Triage Guidelines and some of these crude ways that we're doing it now, and bringing in things like clinical decision support based on waveform physiology and things like that. I think that's where we really need to go, again, to make this efficient so that we're conserving this resource and just giving it to the patients that we know are going to benefit.
Yeah, great commentary. And I kind of went down a rabbit hole recently, Josh, because I was talking to Dr. Holcomb, and this is the talk I was just giving here a minute ago, but looking at the glycocalyx, looking at values like Syndican 1, Syndican 4, and there's studies from 2019 looking at being able to measure those levels, glycocalyx levels, if you will, and looking at outcomes. And it's been shown that in sepsis, that's the case. And someone had mentioned that in Pittsburgh, they're testing. There's some point of care test for TBI that can. And so I wondered, do you have any information on that particularly? And do you think that those types of point of care tests will be able to inform the field medic of level of TBI and whether then that patient should get plasma, which is what our protocol is today, but we just use a GCS of 12 or less. That's our that's our entry. So any thoughts on that?
Yeah. So I mean, those studies we're using GFAP, and Abbott now, they have a cartridge on an iStat that will measure that point of care, and getting it approved for clinical use rather than research use is where we're going. But those studies have shown we can tell who actually has blood in their head. And even as simple as things like some of the bigger TXA trials for TBI showed the benefit was if you have blood in your head. And so now we can tell you who has blood in your head, point of care in the field. And so using those things, and so certainly much farther out, but point of care Syndican, point of care IL-6, and some of these biomarker panels, is on the radar for some of our labs to try to push this, out to something that we could use in the field, and get away from, your blood pressure is less than 90.
Yeah.
Because, at that point, that's a no-brainer, but the people, who really are going to benefit is before they fall off the cliff.
Right. Even, like, I'm even thinking it should be on the sideline of every NFL football game, right? Because those patients are getting TBI that may be microscopic, and maybe you don't need to wait to have a CT positive brain bleed. Dr. Pepe, go ahead.
Just so you know, I can't get my video on, and I'm sitting in my seat here. But I think there are a lot of appointed carriers that, like we just heard out there, UGG for CLIA, right? But and that's going to be a problem. But there are things that are actually kind of available right now that are less of an issue, such as even lactate levels could be available for the bleeding patients. And the other good news is on the TBI front. At least we know for now that, for example, from the TXA study, that it was those, at least TXA was, and I don't think the plasma is going to be harmful at all in the 50% of the patients or 40% who didn't have, a bleed in the head. But it definitely helped if we got it on. But the caution here on everything is what you said before, Peter, is that the earlier the intervention, the better results. And that's why I'm little wary about the study they're doing with plasma up at Northwestern, because they're not going to do it until they get to the hospital after they get a CT scan. So I just, well, for Robert's work, that was the comment. But
Yeah.
I think down the line, and there's so much more than the Syndican is a nice, marker, as you were pointing out. But yeah, I think you're going to see it. One last thing is that I think plasma and TXA, for example, and blood, but plasma and TXA have anti-inflammatory processes, which are really critical to all this. It's not just leaky capillaries. Okay.
Right. And that's all coming to you from 5E on American Airlines.
Well, I think it's 5 Charlie, actually. So. That's great.
So Josh, you've been with us for an hour. We really appreciate it. I want to give you the last word. You have a lot of people on this call who are thinking about it, are doing it. They've heard, this publication. Hopefully everybody will read it, but leave us with a couple of things that you think that we should be thinking about or doing as your top things that we as EMS leaders should be doing as we take it away here.
Yeah, I think the things that really stood out to me at the end of this is the advocacy at the leadership level about the reimbursement, the scope of practice, and being able to take this document and say, this is what leaders in this field, based on the scientific evidence, have recommended. And I think the other thing that's really important, especially for those agencies that are thinking about it and aren't sure, is don't go at it alone, right? There's lots of programs out there that have been successful, and then I know that leadership wants to share the knowledge and sort of the failures they've had, and not repeat those mistakes, and using things like the Pre-Hospital Blood Transfusion Coalition. I know in San Antonio they run a whole blood university to kind of go through these logistics. And so I think don't feel like you have to do this alone and reinvent the wheel. There's a lot of great people in the field who want to help and spread this knowledge. And I think the rising tide raises all boats is really an important concept when you're starting this up.
Excellent. Well, great comments. And actually, to your point, I'm glad you reminded me. On September 17th, in 12 days, we have a webinar set up for advocacy for blood in the state of Florida. We have a special guest speaker, Charlie Sand, who has a history of getting things passed. And so what I'm going to ask all the leaders in Florida under the Florida chapter is that once we get this webinar done, our ask of you is going to be to write and then call your legislatures so that Ken's bill can actually get through and we can get it done in this session. Wayne, I saw your comment, so that we can go live in summer of 2026. So that's going to be the webinar. We already have it planned out. I'll put out the materials. But Josh, thank you so much for all the work you do. You and your team has made a big difference for us to allow us to actually do the work that we're doing. So we appreciate taking the time out today and joining us. But have a great weekend, Paul. Safe travels. Josh, thank you so much for joining us. And everybody, keep fighting, and we'll see you next week.
My pleasure. Take care, guys.
Okay, bye, guys.